Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yasin Taha from the School of Medicine, University of Suleimani, giving a talk on tension pneumothorax, a rare presentation of pulmonary hydatid cyst. You can access this lecture by visiting my YouTube channel by clicking the website at the bottom of the slide. Pleural hydatid disease is rare. Tension pneumothorax and empyaema are also rare. A search through the net revealed less than 60 cases over 60 years all over the world. Farhan Bakir and Al-Omeri reported 5 cases of echinococcal tension pneumothorax in Iraq in 1969 for the first time. To the best of our knowledge, this is the second report. Herein, two ladies with pneumothorax and empyema secondary to intrapleural rupture of pulmonary hydatid are presented. The aim of this report is to emphasize that intrapleural rupture of pulmonary hydatid should be considered in any patient with a pneumothorax in an endemic area. The first case was a 17 years old girl from Basra, south of Iraq, admitted 1 month earlier to another hospital with the complaint of sudden shortness of breath. She was diagnosed with a collapsed lung with hydropneumothorax by the plain X-ray, and therefore she received apical and basal chest tubes and anti-TB chemotherapy on suspicion of tuberculosis. So when she was referred to the thoracic surgical unit, she had a collapsed left lung and hydropneumothorax with thickened parietal pleura and a visible chest tube. The two chest tubes drained thick pus, and there was a persistent air leak, a sign of bronchopleural fistula, and the left lung was entrapped. Therefore, the decision was to do a left thoracotomy for decortication of the left lung. Left posterolateral fifth space thoracotomy was performed, and at the time of thoracotomy, the findings included thickened parietal and visceral pleural peels, a foul-smelling pus, collapsed left lung, multiple bronchial fistulae in the left upper lobe, and to our surprise, there was a laminated membrane floating in the pleural space. The operation proceeded with decortication of the left lung, removal of pus, removal of the laminated membrane, closure of the bronchial fistulae, and the post-operative course was uneventful, with fully expanded left lung post-operative. The second case was a lady of 35 from Samarra, complained of shortness of breath 1 month earlier when she was pregnant. and she had tension pneumothorax as revealed by the plain X-ray. Therefore, she was managed by a chest tube and she was referred to our hospital with a collapsed left lung and persistent air leak through the chest tube, indicating a broncho-pleural fistula. And again, the patient had received anti-TB drugs before her referral on suspicion of pulmonary tuberculosis. The CT scan of the chest of the patient revealed thickened parietal and visceral peels with a cavity in the left lower lobe. The chest tube drained an air leak and the left lung was collapsed in spite of placement of apical chest tube, a second apical chest tube. Therefore, the decision was again to do surgery and decortication of the left lung. So left thoracotomy was performed. There was a thickened parietal and visceral peels. And again, to our surprise, there was a laminated membrane in the pleural space and multiple bronchial fistulae in the left lower lobe. And what you can see here is the thickened parietal and visceral pleural peels, which was removed in pieces. And that was the laminated membrane of a pulmonary hydatid cyst floating in the pleural space, indicating an intrapleural rupture of pulmonary hydatid cyst. So the decortication was performed and the left lung fully expanded nicely at the end of decortication. So primary pleural hydatid disease is denied to exist. It is almost always secondary to pulmonary or hepatic hydatid disease. Pulmonary hydatid cysts may grow into giant cysts due to the elasticity of the lung. Pulmonary hydatid cysts may rupture either into the bronchus, commonly, or into the pleura, rarely. So the incidence of tension pneumothorax secondary to intrapleural rupture of pulmonary hydatid disease is actually rare. A search through the internet revealed less than 60 cases all over the world since 1950. Only sporadic case reports have been published from countries like Turkey, Iraq, Italy, India, Australia, Spain, and Greece. So probably the earliest report was from Australia. Waddell described 6 cases of pneumothorax in 478 patients with pulmonary hydatid disease in 1950. Tomalino described 16 cases of pneumothorax in Spain in 1952. Rakauer and Milwidsky reported 1 case in 1964. Farhan Bakir and Muayyad Al-Omeri described 5 cases of echinococcal tension pneumothorax in Iraq in 1969 in the Journal of Thorax. Xanthakis et al. Described 3 cases of hydropneumothorax in 88 Greek patients in 1972. Cornelian et al. Described the first case of echinococcal tension pneumothorax in UK in 1979. De Sutter et al. Reported a case of pneumothorax following rupture of a primary pleural hydatid disease in 1972. Rolver Suri et al. Described 1 case in Italy in 1989. Agrawal et al. Described 1 case in India in 1993. Fakhri et al. Described 16 cases of pleural hydatidosis out of 297 patients with intrathoracic extrapulmonary hydatid disease in Turkey in 1997. And again, a group of authors from Turkey discovered 5 cases of tension pneumothorax, tension hydropneumothorax, secondary to rupture of a hydatid cyst out of 185 cases of spontaneous pneumothorax treated in their clinic between 1992 and 1998, accounting for 2.7% of cases. Erdal et al. Described a rare case of giant ruptured hydatid cyst causing tension pneumothorax in a patient with a blunt thoracic trauma from Turkey in 2009. So if we look at the pathogenesis of this problem, pulmonary hydatid cyst usually has a peripheral location. The elasticity of the lung permits a huge size. Intrapleural rupture results in air, fluid, and membrane entry into the pleura. Absorption of fluid results in anaphylaxis. Tension pneumothorax may result from a check valve mechanism in which the air escapes from the lung parenchyma or the bronchioles or the bronchi into the pleura, but doesn't return back to the lung. A combination of massive pneumothorax and anaphylaxis may prove fatal, and without treatment progresses into bronchopleural fistula and empyaema. So management, a preoperative diagnosis is usually difficult. In most of the reported cases, the diagnosis was made at the time of thoracotomy. In the acute phase, steroids are usually given for anaphylactic reaction, and chest tube is inserted for pneumothorax, while the definite diagnosis and treatment is done at the time of thoracotomy. So almost always it is misdiagnosed as pulmonary tuberculosis preoperatively because of the high prevalence of pulmonary TB in areas endemic to pulmonary hydatid disease. However, certain observations may give hints and help the physician to make a preoperative diagnosis. So which observations? Residence in an endemic area, drainage of crystal clear fluid via chest tubes, the presence of pieces of laminated membrane which may plug the chest tube, persistent air leak despite 2 or 3 chest tubes, features of anaphylaxis, and examination of pleural fluid for scoliosis may be positive. Also, there might be eosinophilia, and the chest radiograph may show an irregular gas fluid level, and CT scan of the chest, if available, may show the cavity of the cyst as well as the laminated membrane. So in conclusion, intrapleural rupture of pulmonary hydatid cyst is rare. Echinococcal tension pneumothorax may prove fatal. It should be considered in any patient with pneumothorax in an area endemic to pulmonary hydatid cyst. Preoperative diagnosis is extremely difficult, though certain observations may give hints. Definite diagnosis and treatment is via thoracotomy, and thoracotomy should be done as soon as the patient is stabilized and before the development of empyaema. And we stand on the shoulders of the giants. We take the opportunity of this lecture to say a few words about Professor Muayyad Al-Omeri and Professor Farhan Bakir, the 2 Iraqi doctors who reported the first case of echinococcal tension pneumothorax, as we have mentioned in our lecture. So late Professor Muayyad Al-Omeri was born in Mosul, Iraq, 1927. I'm not sure about the year of his death. He is a cardiothoracic pioneer. He had performed the first open heart surgery in Iraq at 1963 in collaboration with late Professor Yusuf Dawood al-Na'man, who was born in 1923 and died in 1986, while the late Professor Farhan Bakir was born in 1926 and died in 2017. He is an outstanding Iraqi physician with huge contributions to medicine in Iraq and the Arab world. He has an amazing CV. You can look at his CV by visiting the SlideShare account. He has an amazing CV with huge contributions to medicine in Iraq and the region. He has practiced and taught medicine more than 60 or 65 years with great scientific achievements. And with these 2 pioneers from Iraq, I would like to conclude my lecture. Thank you for listening and watching. This is Professor Abdussalam Yasin Taha from the College of Medicine, University of Suleimani, signing off.